I'm just trying to get Facebook Live to go live, which it should do by pressing this button, and it's not. Facebook isn't going live, Tara, for some reason. Oh, I know, because I'm pressing my finger on it rather than clicking the button. Okay, so we've got everybody on board. Hello, everybody. I'll introduce myself in case of new people signing in. My name is Diuretic Clare. I'm a GP medical herbalist, trained in medicine in UCD a long time ago, and have a degree in herbalism from the Middlesex University. And 21 years ago, so this is 21 years working as a herbalist and 20 years working as a doctor. So our clinic is in Galway, and we're happy to help at any time. So if you have any queries, just let us know. And I'm going to talk tonight about are herbs safe to use with conventional drugs? And conventional drugs is, which is more orthodox, which is more traditional, which is more conventional. Would you call it pharmaceutical medicine, or would you call it herbal medicine? Because herbal medicine is conventional, orthodox, and traditional. So we'll throw that in to start with. I'm going to, and that's not a bad thing to do, because I'm going to take a global picture from the World Health Organization, no less, in 2019. And one of their aims is to integrate the best of traditional and complementary medicine, I would call it collaborative medicine, through public funds, including essential health services, because as it is, people who make use of herbal medicine professional services have to pay, in addition to their private health insurance and public taxation and all of the other financial supports for pharmaceutical medicine. So the WHO is looking for this to be integrated by public funding, and no system of medicine in the world history has been successful applied on a population basis without benefactors or public support of some kind. In an ideal world, WHO goes on to say, traditional medicine would be an option offered by well-functioning, people-centered health systems that balances curative services with preventive care. So I'm not a minority opinion. This is in terms of sustainable medicine, regenerative medicine, growing our own medicines, being self-sufficient, and rural development. Lots and lots of other good reasons. Herbal medicine deserves a good crack at the whip. Now, I'm going to go into specifics after making a general statement, which is answer to the question, are herbs safe to use with conventional medicine? I would say overall, a resounding yes. And of course, I will have provisos, because nothing in life, living, or the universe is utterly safe or utterly without consequences. And there are red flags for drug-herb interactions. And they are with drugs with a narrow therapeutic window or index. And that means that the dose of the drug the effective dose is very close to a toxic dose. So it has to be, usually there are herbs that are monitored closely and are titrated to an individual person. And they can be affected by lots and lots of things, including herbs. So herbs are just one of the things that you would forensically examine if you have an alteration in the monitoring of any of these drugs. There's a very small list. Digoxin, which is a heart tablet, cyclosporin, which is used with people who have organ transplants, warfarin, which is an anticoagulant or a blood thinner, lithium, which is used for manic depressive disorder or to modulate bipolar disorder, and antidepressants are often on this list, and I'm going to come back to that. but I'll increase it here just so you know that there are things that you need to take into consideration. Anti-HIV protease inhibitor drugs, and a group of herbs, a group of drugs that are not always on this list, but I keep them mentally, are the list of drugs. I also include giving a wide berth and always recommending for a professional herbal medicine opinion for people who are actively taking cancer medication or drugs as chemotherapy for cancer. So always, there are many herbs that are suitable. There are some herbs that are helpful specifically in preventing toxicity of these drugs, but not without herbal medicine professional opinion. So this group of drugs have two things to do with pharmacy in common, almost invariably. There's always an almost. And this is that they affect one of two systems, and generally both. And that's important. So if you come across a drug, a new drug, an old drug, any kind of a drug, if it does two things, which is to induce levels of CYP 450 3A4 and affects PGP activity, then you're in the lookout zone. You know, you need to take professional advice and listen to it, which is quite important. So I'll tell you a little bit about these two substances, and then you'll realize why they would have these concerns. PGP is a cell membrane protein, so it's a protein in the cell membrane, and it pumps out foreign substances out of the cells. That's its job, okay? So if it is very active, you're going to have a lot of activity in pumping out stuff, and that can affect the drug level. That's putting it very, very widely. CYPs are enzymes, or KIPs as I call them, are enzymes that are involved in 75% of drug metabolism, involves this group of chemicals. They either deactivate the drug or they facilitate its excretion. And this group of CYP 450 is involved in 60% of drugs, metabolism of drugs. And the most significant one is this CYP 450 3A4, because it's involved in half of these. So that's why these are particularly relevant. Instead of listing the list of drugs, the other way I can put this is a list of conditions which flag up very highly when there's any concerns about any concerns, and there aren't many, about drug-herb interactions. And they are the cardiovascular system, the central nervous system, and the immune systems. So you're looking at, if you have, for instance, an autoimmune condition and you're on autoimmune drugs, you are likely to want to consult a medical herbalist because that's quite a complex condition and it will be on quite complex medication. So I hope you're not too overwhelmed by all of that. So stick with me. If you're not into chemistry and pharmacology, don't worry about all of this. Just let it drift past you and you'll get a gist. But because there is such a bad rap for herbs and herb-drug interactions, I need to go into specifics to reassure you that these aren't just glib statements, but these are actually having gone into and delved into both the overall concept with medication, and that's often described as a herb-drug interaction. Whereas if you know your herbs and you know the effects that the drug is going to have, then you can use both effectively, especially if it's an as necessary indication. One example would be drinking 2 cups of a good chamomile tea twice a day, while being on as necessary Xanax or alprazolam, which is a benzodiazepine for anxiety. It's not a good idea to take alprazolam on a regular basis because it's addictive. So you want to take as little as possible, as often as possible. So you might want to use a herb like chamomile so that you need less Xanax. But if you look at the herb-drug interaction summaries, they would call that a drug interaction, and I don't. The other common example is Senecot, or senna, and laxatives. And I would virtually always use different herbs from senna. I would use things like Turkish rhubarb and dock, and a lot of nervine, carminative, digestive, soothing herbs and relaxing herbs. But Senecot and laxatives will be described as a drug interaction, whereas I would say that while there are side effects of Senecot, many of the side effects of a lot of the laxatives would be equal, if not more. But it's not a good idea to take stimulating laxatives. So it's an additive effect. And if you have a problem with constipation, for example, herbs will offer a variety of ways of dealing with it, not just stimulation. Not all laxative herbs are drugs, are stimulants. I don't want to give you that impression. Some like lactulose actually act like dates and figs. So I should qualify that by saying stimulating laxatives. And sometimes people, not so much these days, but sometimes people were being prescribed diuretics for fluid retention before periods, when a lot of the time things like dandelion leaf or even nettles would have a significant effect and added benefits of not needing to use any medication at all, or to use less medication. Overlapping benefits also qualify when a herb does supportive actions as well as overlapping actions, so that you need less drugs. And again, that will be described as a herb-drug interaction, whereas to me, it's a herb action and a drug action, and they interact dynamically. And it may be that the beneficial effect of the herbs mean that you need less of the medication. And to me, that's a good thing, so long as it's that you don't need it. And a good example of that would be using fenugreek or cinnamon along with oral anti-hypoglycemics. And the key to this is monitoring. So you might say that some herbs have an effect on blood pressure, that they lower blood pressure. The answer to that is not to not use the herbs. The answer is to monitor the blood pressure and reduce the medication accordingly, in conjunction with your medical practitioner, which can be a medical herbalist or your doctor, especially if it's to do with your medication. Another example would be using sedative herbs like passiflora and sleeping tablets. And if people are trying to minimize their sleeping tablet use, I would advise them to take passiflora at supper time and 2 capsules, for instance, or 5 mils of a tincture at supper time, and then 5 mils before bed. And that way they're likely to need to use less of the sleeping tablets. And sleeping tablets only create problems of being dependent on sleeping tablets and still being insomniac. So that's where I would put the useful overlapping additive effects of herbs, which are often described as herb-drug interactions. You can make up your own mind. There's 2 pharmacological effects of the herbs, which are the pharmacokinetics and pharmacodynamics. One, the pharmacokinetics are the movement of herbs or drugs through the body, in, out, or through, and the pharmacodynamics then is what the drug does to the body. You can remember this if you're herbal medical students. You can remember this by pharmacokinetics affects the KIPs, the CYPs. Pharmacodynamics is what the drug does to the body. So you've got the 3 Ds: pharmacodynamics, drugs, does to the body. So this is what effects it has on the body and what are the mechanisms of action. Most of the research and most of the concerns have arisen through pharmacokinetics. The only herbs known to directly affect PGP in humans are the ginkgo, has an inhibitory effect, and also berberine extract. Now, that doesn't mean that herbs containing berberine necessarily affect the PGP, but it's something to flag up in terms of monitoring your patients for herb-drug interactions. And St. John's wort is an inducer of PGP. And I'll come back. St. John's wort is crucial to understanding all of this. The other consideration is that herbs have more in common with spices and regular drinks, that people use for refreshment and for social rituals and lots of other cues in our day-to-day lives. And spices can sometimes increase the rate of absorption of drugs. Mucilage can decrease the rate of absorption. And mucilage is what you find that makes porridge gloopy. Also, slippery elm and mallow would be considered gloopy mucilaginous herbs. And the most mucilaginous food is okra. And it's that slimy texture. It's more of a texture to a food and often has a slight sweet taste. So if you have, if your pharmacist says that any medication that you're on should be taken away from food, it may be because of mucilaginous interactions. Having said that, in all of the interactions that I've read about, very few of them have any evidence. This is a theoretical consideration for the most part. But that's not to say that if you have porridge for breakfast and okra for lunch and slippery elm 3 times a day, that you're not going to affect, that there's no possibility of affecting herb-drug interactions. Coffee and tobacco increase the metabolism through the liver. I would also say that they both have a laxative effect, which pushes things through more quickly. Whether that has an actual effect on drug metabolism, I'm not sure. So what makes me so reassuring? All of that sounds like, oh my gosh, there must be lots involved in all of this. It sounds very technical and whatever. But it was when I was reading a review, and the author of this review is Awortwe, Awortwe, and his first name begins with a C. And this was published in 2018, so it's one of the most recent reviews, systematic reviews that I've read. The authors are from South Africa. So and the full article is available on the web under PubMed. So it was a review of over 16.5 years, going from 2001 to 2017. They reviewed all of the global literature, which is a big task. They narrowed it down to the most reasonably evidence-based presentations or research. And after all of that, they came away with 47 case histories. 16.5 years, global span of all of the accepted databases. And at the end of that, the most presentable evidence, and much of that is not as acceptable as they would like, or I would like. And the other evidence was 2 observational studies. Now, there's one thing about observational studies that can be stated is that it is a very poor causal association defining powers. So it's not accurate in terms of, it's far from accurate in terms of defining interactions. So when I analyzed this, I was more and more reassured that we were on pretty safe ground with herbs and drugs, because 45 of the 47 reported drug-herb interactions had very, very complicated presenting polyherbal multi-system disease conditions. And I would say that over-the-counter use of herbal medicines is most relevant to people who have mild to moderate symptoms of mild to moderate diseases And unfortunately, there's a small group of people who have multiple problems on polypharmacy who then go, and I can't imagine they say to the health food store assistant that I'm on all of this medication, or the health food store assistant would go, oh my gosh, I think you need professional advice. But some people don't do that. They want to avoid even more medication, I think, so they try out herbal medicines and then they get into trouble. So 45 out of the 47 had very complicated histories. And then I looked at what herbs were involved, and 6 of the case histories involved fruit drinks, 1 involved bee pollen, 1 involved celery root, and 1 involved betel nut, which does have medicinal properties, but it wouldn't be commonly listed as a medicinal herb. And of the 47, the consensus at the end, the professional analysis, was that 4 of these were highly probable. I have reason to consider that on a global scale, given the billions that people spend on herbal supplements that have been growing throughout that whole period, that there really is a very small evidence base. Now, if I was to produce 47 case histories of anecdotal evidence for the benefits of herbs as being a serious contention as to the usefulness of herbal medicines, I would be, I wouldn't get a platform. You know, all of these case histories have multiple platforms, re-quoted multiple times. No matter how sparse the evidence, no matter how much evidence is missing, they're recirculated and not in a flattering way to the herbs involved. It just wouldn't happen. Anecdotes, case histories are anecdotes. This is what happened once. In none of these were the products analyzed. Very few of them had reintroduction. As I say, many of them were on multiple medications, which would equally, with an acute illness, could equally be driven to having drug interactions. Drug-drug interactions were very likely in some of them. Okay, so that's some of the background. So having given you the pharmacology involved and the context, which is very, very little evidence, even on a global review. I'm now going to kind of go into why there's been a huge emphasis for pharmacists, doctors, anybody in the medical business. There's been a huge multiplicity of articles on how dangerous herbs and drugs are. I can well understand why my colleagues are very wary of herbal medicines for their patients on any medication, because every magazine, every medical magazine that they pick up has case histories and wariness and repeating all of these case histories in different combinations. And that's all they are, is case histories. So the balloon went up in around 2000, which is when I completed my herbal medicine degree. And this was big news that St. John's wort was interacting with drugs big time and causing clinical problems. And this was via the very understandable effect on CYP 3A4 and PGP expression. Now, let's update this. This has been updated since 2009, but it was formulated in a very detailed but very definitive manner by a researcher called Nicol Ussi, Nicolussi, and his first name, it begins with an S, and it was published in 2020. So if you put that into Google, you should get up the just add in St. John's wort drug interactions, and this should come up in the full article. What happened was that the scientists identified hyperforin as the active ingredient for St. John's wort. And they started formulating their products with an excess of hyperforin. So it was extra hyperforin wrapped into a whole herb product for the most part. And the USP for these, the unique selling point, was that it had these effective levels of hyperforin. Wasn't happening. Hyperforin is not the active ingredient. In fact, St. John's wort has been declared a herb that is effective because of its collective actions. There is no one active constituent. I would say that applies to virtually all the herbs. So what they were doing was greatly exaggerating the hyperforin content. It's the hyperforin which interacts with the CYP3A4 and the PGP. I'd love to say, this has been known to the European Medical Agency since 2009, and the European medical agencies have declared that hyperforin below the level of 1 milligram per day does not have the effect of interacting with these medications. So you need to check the label, but unfortunately there is no legislation that the level of hyperforin has to be listed, so it may not be listed despite recommendations under self-regulation. It's worth mentioning that Nicolosi also addresses whether there's an interaction with the oral contraception. And his conclusion is that this is an artifact created by increased awareness of possible drug interactions, and that it doesn't stand up when you think about the increased breakthrough bleeding with the lower dose of pills and the pharmacodynamics and pharmacokinetics don't add up. We can also say that the amount of usually prescribed St. John's wort by herbalists traditionally would be 20 mils of a 1 in 3 or 1 in 4 tincture per week, and this in no way has hyperforin levels of greater than 1 milligram per day. This works out at around 3 mils a day or 20 mils a week of 1 in 3 or 1 in 4. Hyperforin is 6% of an alcohol tincture, and it's unstable and degrades rapidly. Hyperforin is not needed for the clinical effect. It does not depend on hyperforin. Herbalists traditionally have used St. John's wort as a nervine, particularly to increase the quality of sleep, the refreshingness of sleep, if you like. It's not a sedative herb. It's also anti-inflammatory and antiviral. So it is an absolutely lovely herb for times of COVID. Also very useful at the menopause, also very useful for children, very useful for SAD. And this is one of the most researched herbs of most benefit for mental health, which is, and there's a lot of overlaps with what happened with Kava Kava. With Kava Kava, it was that because the demand, once they proved efficacy, demand increased. They started extracting cavalactones from parts of the plants not used traditionally. They started manufacturing them in processing ways that altered the whole balance from the traditional use. And so here we have two of the most scientifically proven beneficial herbs for mental health issues, which have gone to global epidemic phase, exaggerated by COVID. So none of which has hit the headlines. You remember all of the global headlines about St. John's wort influencing metabolism. Wouldn't it be lovely to say
that we've all been totally reassured, and we can happily go back to using St. John's wort, and it would all appear back on the shelves. And we're sorry we made these mistakes. Okay. I do have a sense of humor. Okay, so after all of that, I thought I'd go through some herbs that are controversial and that there's a lot of misinformation about. So fasten your seatbelts, here we go. Okay, one of them is licorice. There's the word on the street is that licorice affects blood pressure. Yes, it does, because it has a medicinal effect. It does because it is involved in aldosterone metabolism and the renin system, but only if you eat 100 grams a day. Now, 50 to 70 grams has been defined as a safe level by the European Medicines Agency, the EMA. It has also been determined that if you take less than 6 grams a day, it has no effect. It has absolutely no effect on this aldosterone system. 50 to 70, 50 grams is 21 teaspoons of powdered licorice. Hard to take 21 teaspoons of powder. It is so sweet. It is sweeter than sugar. Medical herbalists generally use 5 mils a week, and that, coincidentally or not, coincides with 6 grams per day, so no effect. Now, I do check the blood pressure of patients that I put on licorice, because if I'm ever taken to medical legal consequences of things, everybody will find it much easier to look at the volumes of anecdotal evidence rather than the scientific evidence. So you just always have to be careful, because the zeitgeist determines the outcomes of things. Okay, I'll mention echinacea as well, because there's lots of articles that just glibly just throw in that echinacea has lots of herb-drug interactions. It doesn't. Okay, it has a very low potential for CYP interference over a wide range, and it has no significant clinical implications for drug-herb interactions. Here's another tip. If you're looking at a herb and how it's metabolized, if it's metabolized by 15 different CYP or KIP systems, then you're much more reassured that it's very unlikely to interact with drugs, because it has such a diverse effect. Okay, so that's also kind of like a reassuring thing to look out for. Right, so there are 2 herbs. I'll intersperse the herbs with general points just to keep you awake. I'm going to just talk about the limitations of these studies, reviews, looking at herbs that people who have been admitted to hospitals, what herbs they're on admission. All of these reviews, meta-analysis, are all done by pharmacists. Now, clinical interpretation and direction is not a key role of the pharmacist. It is a role of the pharmacist, but it's not the key definitive role. That's the responsibility of that is taken by doctors. There's very few doctors on these reviews who might be able to put in, well, hold on a minute, if I'm not to use these herbs which seem to be having a beneficial effect, then I will need to use a drug, and this drug definitely has toxicity and side effects and whatever. Or it might be that it's for a condition that doesn't have a medical treatment, and the herb-drug interaction is quite tenuous. So that's when even a doctor's opinion, I don't mean that I'm very respectful of my medical training, but that clinical voice is completely missing. And I have not come across one of them that has involved a herbalist. No, not one. And I've researched a whole book on herb-drug interactions and the clinical significance. And I would call this a very definite limitation of these studies. I've mentioned that the observational studies have a very low correlation of saying something that one thing causes another. And here's an anecdote. An apple a day keeps the doctor away. Okay, that's folklore. But if I was to tell you that there are case histories of appendicitis where apple seeds have been found in the sample sent off to the laboratory, and there's a question about whether these apple seeds have caused obstruction and spasm and necessitated surgery of appendectomy. So you don't advise the whole population not to eat apples, okay? And inevitably people will eat the odd apple seed. You don't advise them not to eat apples because they might possibly eat apple seeds. I don't recommend eating apple seeds. We're not really capable of breaking them down. So these are the kind of anecdotal associations where if you have 2 or 3 anecdotes to do with a herb, then there's this global that this is dangerous. Linseeds, for instance. Linseeds, you shouldn't use linseeds because it can cause intestinal perforation. Now, I wouldn't particularly advise linseeds because they're quite sharp for people with severe diverticulosis or inflammatory bowel disease. But the more people are admitted to hospital because of a lack of linseeds and a lack of fiber, and there are reports of people who have perforations because they have severe constipation. So I would like herbs to be taken for their benefits as well as their evidence of potential rare possible associated harm. Especially because medicine is a primal instinct. We know this because apes, gorillas, chimpanzees, animals know what herbs and plants to eat in preference if they have illnesses. And this is well documented. Herbal medicine is well informed by archaeology, ethnobotany, all kinds of parallel sciences. And this would draw in on sociology because what medicine we take is culturally defined. Because medicine is a primal instinct, I believe it is a very good reason for advocating, public health advocating the use of herbs for self-help, for self-limiting diseases in particular. And that includes influenza, all influenzas. Whereas the impression is being given that you shouldn't take anything except for the drugs. And the drugs of paracetamol, non-steroidal anti-inflammatories, and codeine all have well-recognized side effects, and some of which can actually exacerbate the presentation of influenza. That's not my personal opinion. That's from an international pharmacy review that I discussed in the last YouTube. Do you know that it has never been proven that herbal medicine doesn't work? There's no evidence that it doesn't work. There's ample evidence that herbal medicines have medicinal actions, some of which have been proven to be beneficial. So worth thinking about that. Herbal medicine, and those of you who know my mantras know that it is digestion, digestion, digestion. And this is to kind of get the impression that herbal medicine addresses the terrain. It doesn't actually address individual diseases. So many of the common diseases today are due to meta-inflammation or micro-inflammation of the tissues. So herbal medicine would use things like the bitter principles all through the gut and drainage and clearance. And herbal medicines will never be popular with pharmacists because herbal medicines are a riot of pharmacy. Okay, we have multiple variations, myriad presentations, all different levels of states of congestion and inflammation in various tissues, which determine what symptoms we have. And balancing that and co-evolved with that is our use of plants. So addressing the gut-brain axis, which influences the pituitary, the hypothalamic, and the adrenal glands, by way of gut peptide hormones. That's the level of impact that we're talking about with herbal medicines. We're not looking to go head to head with pharmacy. And that's why the two go so well together. In fact, I would say that there is a real affinity between drugs and herbs. And the herbs can help lift the load of drug actions and possibly reduce the dosage for some conditions like diabetes, blood pressure, migraine, PMS. Why people are taking the pill for PMS before start trying herbal medicines, why people are taking oral antibiotics before trying herbs for acne, moderate acne, is a question that needs to be asked. And that's the question that the WHO is actually presenting, that these should be part of our essential health services. It's the end of my little rant. Everything that I'm talking about crude whole herbs, and the example of hyperforin and that Malay is a good example. The basis of evidence of crude whole herbs, is empirical science, centuries of post-marketing surveillance, if you like. So I'm not talking about extracts, megadoses. I'm not talking about combined extracts where you have extracts added to whole herb. I'm not talking about liposomal extracts or exaggerated extracts. Because these need additional research for safety. You can't rely on evolutionary knowledge for that. Adverse events or interactions can't be interpreted for whole herb. What's happening is you're getting herb-drug interactions with these exaggerated mega extracts. And then that is being applied to crude whole herbs, as happened with St. John's wort. Okay, so I rest my case, really. Okay, so we'll go back to another herb groups, and this one is diuretics and lithium. Diuretic herbs include tea and coffee. Okay, most definitely. If you have 2 liters of fluids a day and 900 mils are coffee, then you will end up with a negative fluid balance. Right, so lithium doesn't come with a warning, don't drink tea or coffee. Very few herbs can match black tea or Camellia sinensis and the coffee with caffeine in terms of strength, right? So these are all based on theoretical considerations. So you'll see, if you look up alfalfa in the Mayo Clinic or medscape.com or any of these websites, they'll say, oh, caution with diuretics. And the common ones listed as such are alfalfa, silver birch, horsetail, elderflower, dandelion leaf, yarrow, and quite a number, celery seed, quite a number of other herbs. And they do have mild diuretic effect, but there's only one case history in the whole of the literature that I can find. And this was in a letter to the editor. And the significance of that is it didn't go through any peer review or scientific evaluation. And they're more likely to have lots of missing data, relevant data. And the person involved in this case history of diuretics and lithium was on hydroxyzine, sertraline, diazepam family, propranolol, which is a beta blocker, risperidone, which is for mental health problems. So that is implicated in prolonging the contractility aspect of the heart, the QT interval it's called, and also influencing CYP3A4 and PGP alongside lithium. Now, if there's a drug-drug interaction, that's it. And this person was on the highest level of lithium dose, not advisable for management in the community. She presented being sick and dizzy and whatever, and her lithium level wasn't reduced. And it was only when she returned that they thought, oops, this might be lithium toxicity. She was also taking antihistamine and paracetamol for sinus problems, so she could well have had a temperature or fever. She denied going back on alcohol, but had had serious bereavement and difficulties in the previous 6 months, so that an alcohol level wasn't taken. So, and this is the one case history, and I'm just using that as an example, as to how these things are set out in the literature, which are then rehashed over and over again, no matter how bad the evidence is. And that's an anecdote. Nothing was tested, nothing was retried, nothing analyzed. And this is very common with all of these anecdotes. So, okay, let me have a drink of water. One more group, I think, yeah, which is the plant estrogens. And then you'll have earned your attention. I hope I've earned your attention so far. Okay. So plant estrogens or phytoestrogens. Phyto just means plant. So these are plant-derived estrogens. Now, as I said before, both plants and humans are complex. That's why I love the herbs. Commonly quoted and accurately quoted herbs containing plant estrogens are Chinese angelica or Angelica sinensis, Medicago sativa or alfalfa, and Trifolium pratans or red clover. The most recent overall consensus is that there is no conclusive evidence of harms from complex metabolic effects of these constituents. And the summary also says that there's a probability of benefit for cancer treatment. And I repeat again, for treating cancer, it's always better to see a professional medical herbalist. Whether plant estrogens have an estrogen or an anti-estrogen effect depends on the terrain. Okay, this is where herbal medicine comes in. If you can imagine, we go back to the pharmacodynamics, pharmacokinetics, that this is where the receptors, the estrogen receptors, if you have a lot of estrogen, biological estrogen in your system, they will link onto these receptors on the cell walls. If you have very little estrogen, then there'll be lots of empty receptors. When you take the plant estrogens, they will, if they make it to the receptor first, they block some of your powerful estrogens, and estrogen is not always beneficial. Too much of anything is a bad thing. Too much estrogen is a bad thing. And it's implicated in cancer occurring. So if you have too much of a biological estrogen effect, the plant estrogens will block it. If you have too little estrogens, which can be very helpful for cardiovascular health and for bone health, particularly for osteoporosis. So I'm not making any claims, but it's a likely benefit. So it depends on the terrain. It also depends on your gut flora. So I'll come back to that in a minute. Selective estrogen receptor modulators are non-steroidal estrogens that are anti-estrogen because of their side chain positions. And they overlap with foods and herbs. And the constituents implicated or involved are flavonoids, lignans, stilbenes, and comestins. That's the science. They're present in soybeans, grains, fruits, and vegetables. All the things that are healthy. Okay, so I'm not going to tell you to stop eating them based on some theoretical concern that somebody has put two and two together in a join the dots exercise of scientific evidence. I love science, but it does have its limitations. Now, these plant estrogens are metabolized by the gut flora to additional derivatives that affect estrogen activity. So a healthy gut flora is a very good idea for getting the most benefit from your plant estrogens. All of this relates to foods and whole herbs, not extracts. I cannot give these reassurances for soya isoflavones that contain daidzein and genistein, and we do not grow up co-evolving and getting an appropriate amount through foods. See, we've learned a lot about what healthy foods to eat over the multi-centuries. And most traditional diets whether it be the Mediterranean diet, the Greek island of Paz, the rural Indian diet, they all end up with a lot of wisdom, and nature has defined, and then we have grown agriculturally a lot of the right balances and densities of foods in these traditional diets. So I can't say the same for extracted constituents given at megadose levels, and I think you'll find that that's quite reasonable. Another research article in 2020 proposed that plant estrogens in foods have a role to play in obesity and preventing type 2 diabetes, which when you look at its constituents and look at its foods, you would put 2 and 2 together or 5 and 5 together and say, you know, that's quite reasonable. And that's what I like about the herbs. In addition to looking after your plant health and bone strength, you also have fiber and lots of other things that when they're looking at herbs in a research setting, they're looking at one herb in a particular group of people, which usually doesn't include people who are unwell often. So you're looking at very small, discrete pockets of information, which is why I really trust the traditional knowledge first and foremost. And then if somebody has acute serious illness, they should see a medical herbalist anyway. And then you might be talking about looking for specific benefits or healing in a way that is needs a more firm way of acting. Herbs work. If I want to move a mountain, I can bring in a great big JCB. I'm talking about a hill, a big hill. Or I can bring in 50 people of earth, right, not rock. I would bring in 50 people with buckets and shovels. In either case, the hill will be moved. The 50 people might take a bit more time, or it might not be so dramatic. And herbal medicine is about that very undramatic, incremental, it moves like a train, gradually moving around curves, rather than a car or a bicycle that can do 90 degrees. Okay, so, or the other way I describe it is a tack hammer rather than a sledgehammer. So I'm going to, at the end of all of this, I'm going to say your drugs to watch out for, let me get my list again, is warfarin. Is this the timing right, Tara? Okay, you're doing great, lads. I just want to re-emphasize, where's my page 1, that there can be problems with drug-herb interactions if you are on, and these account for like 85-90% of all the reported interactions. Digoxin for the heart, cyclosporin, organ transplant, warfarin, blood anticoagulants, lithium for bipolar, I know that's not quite the right term these days, HIV protease inhibitors, HIV, IAD anti-arrhythmia drugs, and anybody who's on active treatment for cancer. Herbs can be useful, but I would always refer to a medical herbalist, and that would be for supportive collaborative management, according to the patient's values and viewpoints. Okay, you're brilliant. Take care. Use the herbs wisely and safely. Quick question. I would always use crude whole herbs first, whether that's turmeric, and the great big hype about curcuminoids to do with bioavailability. Bioavailability is only the amount found in the bloodstream. It doesn't account for what's absorbed across the digestive system wall, what's brought directly into the lymphoid system, what the effect is on the microbiome, which might create an effect on different peptides and secretions. So it's far too simplistic, and we risk going again and again into the whole hyperforin cava. And as soon as something is found to be effective, like turmeric, you'll find that there are all of these patentable derivatives. So I trust Mother Nature, right? If you have very advanced disease of some kind, but that's very much dependent on the individual person's terrain, the complexity of whatever. But it's not that there's a generic condition that I would use standardized extracts for in the first place. Hope that answers your question. Somebody asked for recommend a spring cleanse. We have a detox blend, which is very nice. Breach, hello. I'm sorry, the reception is breaking up a bit. Anybody can say good night, goodbye. So that's the main question, I think. And yeah, take care, everybody, and stay safe. All the best. I'm not sure how to finish the YouTube one. Pass you over to Tara there. Oh my goodness.
Thanks, everybody.
Boy.